I deal with 50, 100, 1,000. Their utility is so important to understand and look at how we it. When we know that you also swelling of permeability, severe patients with electropathy, patients with stroke, surrounding releases a very huge amount, then somebody can get strain on the heart from that stroke. But that does not mean heart attack. Bystander necrosis, other situations where hit, there's a country if you're playing cricket, hit there, or football, which usually it's cricket balls, can get us. You can actually get us. So in the 1990s, it was shown that patients with the positive troponin could get early medical intervention. So the whole question of the troponin is, does it therefore make a difference to medical systems? Why should we bother with measuring? Why are we then subject patient care to study? We those that use the troponin versus those who use say basic able to detect acute myocardial infarction faster, and they're able accurate in their detection because the can be released for patients with and you know, somebody was jogging early in the day can release the cane. It can also happen in some for inexplicable reasons. So the accuracy of troponin is past the specificity was helpful, and its cause was helpful. So you could make decisions to situation in some hospitals, and particularly in the first world where costs are particularly very high, that you would be ruled in for a medical infarction, or ruled in a protocol where the robot is at home. That saves Medicare money. If you're positive, you're ruled in. That means you get in. Even medical aid, you're less likely to make a mistake when you use a more sensitive marker with early release. So the testing showed that you could do this. And it was strong enough for us to redefine clinical where we're not using troponin. We don't have CKMB. We have CKMB mass. CKMB mass really helps us patient as well to fear for surgery, cutting to the muscle. It release everything. Even CPA because we cut the chest. 2 days later, if one of the graph goes down and the patient is not having a heart attack, the CKMB will come down. So if it goes up again, then we know that this is coming from the heart. Because of its release, it hangs in the system for a couple of weeks. So you find they still have a place for CKMB in situations and other markers. So let's not throw them away. Let's just remember where they lie in our management situation. But the definition in the emergency department, in the doctor's clinic, so patients present to us, that will be based on the clinical, the ECG, and the positive troponin. There are times, I should mention this now, that you get a positive troponin in the patient. These are patients who have characters. These are the patients who have, I think I should have because it's just an idea. So this patient shows up at the clinic and say short breath. Our knowledge is actually very clever. This one is up. If this guy's short breath, I don't see anything. I think I should admit him that's cancer flight. So I said, okay, well, cancer flight is evening, but don't scare. It's a cardiac cardiomyopathy. Indeed, cardiomyopathy. Maybe the muscle was thickened and now she just releases. So we find 33 to 30 at the end of the week, the 4 week. So these to the big cell mass, myocardial cell mass is releasing low grade troponins. So you take context all this so that you realize when you're doing the lab test what it actually means when you see a positive it may not necessarily mean you're dying tomorrow, but it's important. It's important to also and resolve the patient. And totally can that's it. So again, it helps us to assess patients, assess risk, and also guide in their operate. So the true 99%, this is came up because the since measure population. Now the highest safety troponins which we mentioned, I think, yeah, over here, they tend to detect very low levels. So how the issue will have a detectable troponin. So if you take the 99% out of it and say people who have less than this are completely normal. On the other end, the people who have greater than 99% will have suspicion for microsis and try to patient variation. And if you're finding a large testing, you can then be able to detect that this is the variation, and that's when you go a little lower, trying to escape under the radar. So that's a concept you can pick up, but it's just a troponin test. So that they're now able to detect measurable cardiac troponin at lower levels than before, or the sensitive troponin. And what does that mean? Now, when they first came out, again, the United States refused to use this. We did. We were basing our discussions on what it means to us to be able to detect early in situations where you don't have cardiologists sitting in casualties and all over the country, because if you don't have cardiologists, that level. Current generation pick up at that level. These are the normal troponins that we do, and the high sensitivity troponins will pick up even lower levels of cardiac troponin and pick them up very, very early, so you can start treating. Now, when we pick up a heart attack within an hour of treatment, we can actually abort the heart attack. We can get you back to near normal heart function if we catch you early. So it's important to us, because we're not sure about a patient, then sometimes maybe out of every 5 patients, there are 2 that we're not going to be too sure about. It helps us. Okay. Now, this is the same thing. Just, that at very low noise levels there's no acute myocardial infarction, but remember we're doing serial testing. If the patient jumps into this level at 0 hours and at 6 hours, although we have a 0 to 1 hour, then you start saying it's possible. This is when you triage that patient into a possible acute myocardial infarction and you confirm that with further testing of various types. So again, just mentioning that the high sensitivity will pick up more pathological disease than would the normal conventional assays. But remember that in the normal conventional assays, you're missing people here who may have some disease, and you've also got people who are quite normal, but there's some overlap at this level between normal patients and patients who actually have pathological elevation. So the high sensitivities have just moved us this way, detection, but of course, making it mandatory that we must be clear what to do. So this statement is important because there's no point doing a troponin in Professor Mayo's 1-year-old. They must have a high pretest probability. That means that this patient should be the kind that you're looking for. You know, when I get a lot of school children, by the way, brought by their parents, 10 years, 15 years, and I tell them I'm not a pediatrician. They tell me, no, check. We think there's something wrong with the heart, and we check. And we find that, okay, we'll do a troponin. Now, to my surprise, things like pericarditis, these patients will get inflammation. Were negative, and we then started saying, you know, there's no point testing kids who are unlikely to have cardiac disease. So you've got to be able to go back and start asking yourself, how do we pick up pericarditis? How do we pick up rheumatic fever without having to do the troponins? Stop being lazy. Do the clinic. Testing only people who are likely to have acute coronary syndrome is when the test may mean, you know, may have a meaning. But there are those outliers that I've just mentioned that may have a positive. So the diagnosis should be made only under consideration of patient history, total ECG, and then you interpret these in a well-defined and validated algorithm. The validation of the algorithm plus that gives you the kit. This is more or less the same thing. The level of cardiac troponins, normal values, cardiac damage caused by non-acute myocardial. I want to focus on this group. There's a group of patients who they'll be sick, they'll come in sick. And I get called a lot, ICU patients, then ask, okay, what are they in here for? Pneumonia. They're on a ventilator. We don't consider that to be a critical problem. You just monitor. Because the first time the test came out, a few of these patients ended up in our cath lab. We're looking at the arteries, we're finding them normal. COVID, by the way, was a big problem. A lot of patients with COVID had troponins at this level. Then you start asking yourself, you know, what does that mean? Many of them did not have